Okay.
So now I'm ready to hook my patient to suction if that's my order. So I have my suction adapter here. I'm going to place it into the suction tubing, and then you can see over here on the wall, we're attached to the suction reservoir. And at this point, if this patient really did have a bowel obstruction, it would likely be filling full of gastric contents right now. So I would know that my tube is intact, it is decompressing the stomach like it's intended to do, and I'm all set up and good, and my patient's feeling great at this point. She's probably proud because she's no longer vomiting everywhere. We are doing that job for her, so this is a huge relief for the patient, which is really important. Okay, so now let's move into the difference in the DOB-HOF or the feeding tube, okay? So for removal, while I'm here, I'm gonna remove this tube and teach you how to do that. Okay, so Janine, I'm gonna talk her through. We're gonna remove your NG tube today. Yay!
Oh, good.
So well, we're gonna try to get you to eat today, so we're gonna take your NG tube out. There's a couple things I need to tell you. When I ask you to hold your breath and bear down, I want you to do that for me, and this is gonna be real quick. So you may wanna have a bio bag or a garbage bag, whatever, but this does need to go into the biohazard bin. Okay, Janine, are you ready? So I'm gonna remove any tape that I have. I'm gonna make sure that it's no longer draining. I wanna make sure that it's clamped. So you can put your clamp in there. Some of these do have clamps. So Janine, I'm gonna ask you to hold your breath really quick. 1, 2, 3, hold, and I'm gonna remove, okay? There may be a little blood residue or some scabbing here. You wanna clean their nasal area really well. You wanna teach her that likely there would be a little bit of blood there, just for her to monitor that. And she's gonna just thank you so much for getting this out of her nose because it's very uncomfortable. And then you would discard that in your bag and take it to the bio bin. Okay, so same scenario for the FlexiFlow tube, just a little bit different because we do have that stylet like I mentioned. We're gonna measure the same way from the nose to the ear to the xiphoid process, and I'm gonna go down again, and at this point she's at about 75 plus three little ticks here, so that would be 75, 76, 77, 78. It's very important on this one that you note exactly how far this went in, because this tube is not used to take things out of the patient. This is used to put things in the patient, like medications, feedings, all those types of things in food. Okay, so I'm gonna go to 78. The stylet is in and intact. My extra valve here is closed. I'm gonna do the same thing and have her chin to chest. This one is a lot harder to manipulate, so this is really important. And this may be the patient that can't swallow. They may have a poor esophageal reflux, or they have terrible dysphagia, so you may not be able to use that ice before. So that's your discretion and your knowledge of your patient. That's very important. So I'm gonna go until I get to 75. I'm going to tape and secure this, just like before. This time, I may actually need to use my side port here because my stylet is still in. So can I attach this with my stylet in? Can't do it, can you? Okay, so 30 of air, but I can manipulate this sometimes, or you can get a 3cc syringe with a lure lock, which I don't have. That's okay, we'll just pretend. So pretend that I have a lure lock here. I can add a small amount of air here to still hear my gastric bubble. With my stethoscope, I'm going to attach my syringe and I'm gonna listen for that sound as I inflate. And this is not a slow thing. You wanna push this really fast so that you hear that bubble come through into the stomach. Okay, at that point, I'm gonna close off the side port, because if any gastric contents were in her stomach, it's gonna drain through here. So you're gonna make sure that this is closed. You also wanna make sure that your stylet stays intact until your x-ray is confirmed. So at this point, if you felt pretty good that you had air bubble, you're in the right place, you heard it, you can't really auscultate or aspirate a whole lot out of this port. Plus it's so thin, it's gonna, just like sucking a small straw, this is going to cave on you, I guess that's the word. So now I'm ready. I feel confident, and I'm gonna send my patient to x-ray because that's the placement verification that's required. I'm gonna send this patient to x-ray. She's gonna go to x-ray, it's taped to her, secured. Another thing to think about is if she's fighting this or doesn't like this, then it's probably best to do a bedside x-ray so that you can be with the patient before the x-ray procedure so that she doesn't pull this out in the meantime. But Janine's very agreeable. She's very involved in her care, and she's gonna be fine. So we get the x-ray confirmed, the radiologist confirms that it's in proper placement, it is intact in the stomach, And they say from their standpoint that it is in good placement. That does not necessarily mean that you have an okay to use order. At that point, you've got to give those orders to the attending doctor to say it is in proper placement. Can we use it? That doctor would give you the okay to use and then probably order whatever type of medications and feedings and fluids that the patient would need. At that point, when you know it's okay to use, you're going to remove the stylet. And it is a sharp because it's sharp on the end, so this needs to go in the sharp box when you remove it. And at that point, it opens the tube for you to be able to access it to any of your feeding devices. You can see that. And then you wanted to secure it, so you'd remove the stylet. I'm gonna leave this in here because this is a great one to practice with. The purpose for that is, once you remove this stylet, this is a much more comfortable tube for the patient as opposed to this large bore one. This kind of works with their natural pattern of their esophagus and into their stomach. These can last a lot longer. There's new research about how long these can stay in, and we'll discuss that in class, but just know this one can stay in for quite a bit longer than the actual decompression tube. But that's the main things with those. Okay, so next I want you to look at our other kind of gastric tube, and that is the PEG tube. So Janine has a PEG tube, percutaneous gastric tube. It's going to be in the stomach. It looks much smaller. You see here on the valve you have feed, and then this one is never use this port. This looks just like that port that Ms. Cuvion used with the Foley. This is the actual balloon port that has this inflated into the stomach. If you were to ever aspirate air or work with this PEG tube is going to come out of your patient. So just like with the Foley, that balloon is what sits inside the cavity of the stomach to allow this tube to stay in. This is called a bumper. This is the bumper of the tube, and it's inside. So what this is, a plastic reservoir that kind of helps that sit on the outside of the stomach. This does need to be pulled up and cleaned, and the skin does need to be inspected around there every day. So I can kind of show you here, since they have taped this for me. But it's going to sit just like this, and that's really for comfort. Sometimes you may see a gauze around here. Gauze, our rule of thumb is gauze can only be on any type of patient skin for no more than 24 hours. So if that gauze has some drainage, has some exudate, you do need to take it off. You need to inspect your PEG site, which would mean you're going to pull that bumper up and look all around that area. Her skin looks really good. And you would clean, you can clean with soap and water or any type of medical grade orders that are done. Some people use peroxide, some wound care nurses have specific, they use saline, so just use whatever's ordered for that patient. So we're going to inspect the PEG. We're going to make sure that the site looks good. There's no drainage. It looks really well. Before I do anything with my PEG tube, I always want to check for placement, right? Because we don't want to ever put anything in our patient until we know that it is properly placed. So just like with my other tubes, there's a lot of contrary beliefs about assessing for air. I'm going to do it just to show you again that it can be done. But for this one, you're going to listen right beside the PEG. So you'd put your stethoscope right here, you're gonna insert the air, and you're gonna hear your bubble. It's gonna sound just like so. Then I'm gonna aspirate, and I think she has some stuff. She's supposed to. But I would aspirate until I could not see any more residual. So if that means that I got a full 60 and I still felt like I had some more, I'm gonna leave Janine right there for just a second, and I'm gonna grab my graduated cylinder. Probably going to set it in a place that I know that can be secure. And I'm going to insert that in here. Going to flush it in. Okay, that was 60. And I'm going to keep going. Okay, so then I pull back really good, and now I only got 30. Okay, and I don't see anything else coming out of her PEG. So 60 plus 30 is 90, right? 90, that's my residual for her. So 90 residual. So she had 90 residual in her abdomen, which is a good number. So at this point, I'm gonna need to draw every bit of that back up. Fun, right? And I'm gonna give that back to her because this has all of her gastric enzymes. It's got a specific pH for her body with all digestion in there. So I'm gonna give that back to her. So slowly, I can slowly give this back. I prefer to do it very slowly. You could gravity this in, but since this is her stuff, I'm gonna use the syringe where it's more of a closed environment in case I were to spill. And then I'm gonna draw the rest of that 30 up, and I'm gonna give that back to her very slowly. Okay, so now I know that her peg tube, gastric tube is in proper placement. I checked by auscultation, aspiration. She had 90 gastric residual in her belly, and I could give her food, fluids, medications such as. So now I think I want to prepare her medicines. So if I'm going to give Janine some medications, she's NPO by mouth because she has a peg tube, meaning there's a reason that she cannot swallow via mouth. So I'm going to give her medicines via the peg tube. So the first thing I want to do is I would clean my hands. I'm going to prepare. So I'm going to give her, she's been running a fever. It's COVID, right? Fever, we got to treat her fever. So I have Tylenol 160 milligrams for 5 mLs. So my order for her is 160 milligrams. So I'm going to give her 5 milligrams of Tylenol. I checked her computer order. I checked the order. I've got what I need. So I'm going to measure out 5 milliliters here. And we know that when we're accurately measuring, we're always supposed to look at it on a flat surface, right? To get accurate 5 mLs. Okay, so that looks exactly like 5 mLs. It's not a narcotic, but I do want to make sure I'm not ODing her on Tylenol, right? So 5 mLs of medication. So typically when a patient has a tube, they're going to try to order as many of the medications in a liquid format as possible for formulary. But there may be medications that you're going to need to crush, or capsules that you will give. And if you were good to give her a capsule, do we crush capsules? Absolutely not. So make sure it's a proper type of medication. A capsule would actually open the contents into here, and then we would be able to give those. But for medications, the rule of thumb and textbook specific states that before any medication administration, you are to flush the tube with 30 milliliters of water. So to flush, I'm going to do that by gravity. So I'm going to pull my plunger out, and I'm going to usually need to get a towel or a great little towel here. Get a towel, and I can take that out too since I need that. Because you are going to get them dirty, and maybe yourself. The more you do this, the more proficient you will be. So the first thing I'm going to do is either unclamp the tube, and I'm going to clamp here, and I've got my water close. So one of the biggest things that you need to do is to be prepared, because you don't want to be over here reaching for your water. But my plunger is out. I'm going to open up my tube here, and you see how I have this clamped here? This is allowing whatever's in her belly to not pour out into my tube, but it's also not allowing air to flow into her gut. We know when we get air into our gut, what do we have? Gas. No one likes to feel bloated. No one likes a lot of gas, so you need to do your patient a favor and pinch here. So the first thing I'm going to do is, if you see my syringe, I have it clamped. So do I know that there's 30 milliliters of water in this cup? Absolutely not, but I have this clamped and put. So when I do that, the only thing, nothing's flowing in until I let the pinch go. So here's my 30 milliliters of water going into gravity. So I'm going to hold it up, and you can see that my water is flowing to gravity. So I'm just flushing, making sure that her tube is working and patent. Seems to be doing great. And then as soon as I see that get to the end, why did I pinch it off? Because I don't want any more air to go into her belly or her stomach. All right, so I've measured out my Tylenol. It's 5 milliliters, so I'm going to do the same process here. I'm pinching here. I'm going to put in my medication directly into her by gravity. I'm going to hold it up, let it go, bring it back down. She's only getting Tylenol at this point. It's the only medication that we're going to administer at this time. But I always, after each medication administration, I'm going to flush with 30 before to assess patency of the tube. I'm going to give my ordered medications, then I'm going to give 30 after. So I'm going to pour again. And I wasn't pinching very well, Miss Mobley. 30 milliliters of water. And now I'm flushing all that medication into her stomach to allow her to absorb, so that she gets the effects of that Tylenol quickly, because she's running a fever and she needs it. And then I'm going to undo and clamp her back. So that was giving medications via a peg tube. The same concept for an NG. If you were going to give medications, you still need to assess placement. For this tube specifically, this tube The FlexiFlow is the highest risk for aspiration tube than any of these because of its placement. We know that we're likely not giving anything in this tube. This one, if we were ever concerned that we were not in proper placement, we didn't hear that bubble really well, we didn't get gastric contents, it is always appropriate to back that up with an x-ray for this tube. Because where might you infuse something in this patient accidentally? The lungs. If this coils up, that can go back into the trachea and you end up causing aspiration and fluid into their lungs. So this tube in particular, if there's ever a question about your placement, always get an x-ray. But you're gonna do it the same exact way. You're gonna use it. A lot of people prefer to use the plunger in giving with NG. Textbook says and NCLEX says it's always best to use gravity, but you all know in the real world you may say other things. The biggest thing to realize is that you just must push this very slow. You never ram anything in to the gastric system very fast. We all chug water when we're thirsty, but we cannot do that with these tubes. That's because of the type of durability of the tube and the plastic that these are made of, okay? Okay, so same thing with feedings. Let's say that Janine, it was time for her to get what we call bolus feeding. You're gonna practice this in skill set, yay, yay. But I'm gonna show you. For a bolus feeding, we're gonna do the same concept. We're gonna make sure that our tube is in proper placement. Do you think it would be a good idea to do that Tylenol and all that water and then immediately give her a feeding? Depends on the patient, how much they can tolerate in their bellies. Janine's a very normal size. She's probably used to eating normal sized meals, but every patient is very individual and we've got to treat them that way. So it might be that if her meds were due at 9 and she needed a morning feeding, I may give her medications because I'm going to prioritize those first because she may need blood pressure, she needs the Tylenol, and then I may wait 30 minutes to an hour as long as I'm in the proper window for her nutrition to give her that to allow her body time to digest those fluids. So the order said that she needed Ensure Original Vanilla, and she needs 1 bottle every 6 hours or every 4 hours. So that would be this entire can. So what I would do is I would prepare my solution. So I'm gonna pour that into a clean cup, clean reservoir. I'm gonna pour that in there, or you could just pour directly from the bottle, however you wanna do it. I'm gonna teach her about her feeding, that she needs to let me know about any signs of cramping, any shortness of breath, anything that would tell me that she might be having aspiration or feeding her too fast, which would cause cramping, hurting, bloating in her abdomen. So generally speaking, you're gonna do the same thing. I never give feedings with a plunger. I always pull my plunger out again. I've checked for my residual. She had no residual, so I know she's good to go. Her belly's ready to be fed, her stomach. So then I'm gonna do the same thing. I'm not letting air into Janine, and I'm gonna pour directly from the can and go by gravity. If you notice that the gravity is starting to slow down, then it might mean that we need to give her a little bit more time. She may be getting very full very quickly, so it may mean that we may need to take like a 20-minute break with Janine. But if she's tolerating well, you don't notice any signs, so you not only need to be focusing on her abdomen, looking for bloating, distension, uncomfort, but you need to be talking to her. Janine, you feeling okay?
Yeah, I feel okay.
No cramping?
No, I feel okay.
Okay, great. Well, then we can keep going. So I'm gonna keep giving that to her until I give her the amount of fluid that she needs. But let's say that midway through the can, that Janine starts belching. And she tells me that her stomach's feeling kind of tight. I just don't feel right. I feel gassy. You know, it's time to stop cramping. We're gonna immediately stop feeding her in that moment. And we're gonna assess the situation. So we would listen for bowel sounds. We're gonna assess her. We're gonna make sure that we listen to her lungs, because if she's cramping, belching, telling me that she's a little bit short of breath, what am I concerned about? Aspiration. Can they aspirate from a PEG feeding? Absolutely. Can they aspirate for an NG feeding? Absolutely. So we want to just make sure we're checking those things out. But all is well with that. Now, let's say that Janine needed us to do a continuous feeding. So the bolus feedings just weren't really helping her meet her nutritional goals. So the dietitian came in and decided that we need to put her on a continuous feed. So what I need is what we call a kangaroo pump. And I need kangaroo tubing, which is this. And we're gonna, again, go over this more in class when we start to talk about GI, but this is to help you for clinical for sure. But you'll notice that you'll have a hydration bag which has the blue top, so blue water, and then purple for feeding. Okay, so each bag. The best thing to do first is to prime the entire line with water. And this is tap water, guys. Do we ever put saline or sterile water into our guts? Sterile water is appropriate if you have a case of a patient who may be immunodeficient, and tap water may or may not be the best choice. Sterile water is okay, but typically speaking, we're drinking water right out of the tap, bottled water, whatever, but that's completely appropriate. You do not put saline in anyone's gut, because what is that changing the concentration of? The salt, sodium chloride, okay? So we're gonna fill that with water, and it has this little attachment here, which I'm not gonna fill this all up because you can get the drift. All right, and then the order is for her to have, let's say, Ensure or Jevity 2.5. So I'm gonna find that type of formula. So we'll just pretend this is that formula, and I'm gonna pour that formula directly into this bag. So let me be clear, I've got some pictures for you for when we get to class, but this is considered an open system feeding bag. That means we had to open a container to pour into this bag, which means this particular setup here can only last for 6 hours. If you have a closed system sterile container, which I'll show you some examples of, those are changed every 24 hours. We'll get into that more in a class, but I'm just letting you know this is an example of an open system feed, okay? So I've poured my solution into this bag. I'm going to set it up here. I'm going to label both of these, and I may even write on here open and the change time, change in 6 hours, so that's gonna be 6 hours from right now, and I'm gonna place that on there. I'm also gonna name the type of feeding, because you don't have the label here telling you what this feed is, so you wanna make sure that you know that this is Jevity 1.2 or whatever the orders indicated that you needed. So we're gonna prime with water, and then we're gonna prime with the feeding. So this attaches in here, it rolls around up in here. And you'll probably get to practice this a lot. Of course, you've got this little stuff here. So this is your, what we call a kangaroo pump. This one's Covadian or whatever, I don't know what the brand is, but when we start a feed, we always want to clear the original settings, and you see there's lots of different things you need. You can prime pump. These are not manual primes. The pump itself has to prime this. So you would select prime pump to allow it to prime your water and to prime your feed, okay? We don't actually have volume in there, so we can't do that. We also can adjust our bolus, and we can adjust a flush. For this patient, her orders are that she's gonna be flushed every hour with water, and you'll probably have a certain amount. So the interval for the flush would be every, oh, that's by tens, isn't it? I used the wrong one, 1 hour, okay? Every 1 hour will be our flush interval, enter. And then our flush volume, let's say the order said that she's gonna get 60 milliliters every hour. So that's basically as if she were drinking 60 milliliters of water every hour. So find your area of unit here, measurement, 60 milliliters. Flush interval, so it says flush 60 every hour. And then we're going to say done, and then we're going to adjust the bolus rate, number of boluses, volume, bolus interval. So the rate would be whatever your hourly rate would be. So our order said, let's say 30. That's what our order said. So 30 milliliters of our feeding. And then every hour, it's going to automatically give your patient 60 milliliters of water. So we've assessed again for the umpteenth time, patency of the tube. We've flushed it, we've listened, and we've aspirated. We know that the patient is intact and ready for their feed. We're going to make sure that we have connected that valve in there really good, because if you don't, and this pops out, guess what's all over your patient? You didn't see that this came off, and you just run feeding all over them. And a lot of times, this does have a lure-like feature. Sometimes this will just be inching out a little bit, and guess what's flowing out? Gastric contents. So make sure you got a really good seal there, and then we're gonna hit start on our pump, and then we're gonna assess our patient with how they're tolerating their feeding pump. I hope you all will get time to practice this and practice, because I know watching it's not quite the same, but just keep in mind that you know what type of product that you need, whether it's gonna be a bottle or a bag, and then make sure that you're always assessing patency before you begin. Okay, If she were going to leave the unit to go for a procedure, we always want to turn this off. And what position of the bed should the patient always be in if they're in continuous feeding? They need to be up. Never have a patient laying flat. So let's say that you needed to change her or give her a bath. You can hit the pause function on here. They'll just pretend. It says hold. You would hit hold, lay your patient flat, roll them, manipulate them, move them, get them comfortable. Head of the bed always needs to be 30 degrees when you're gonna resume their feed, okay? So keep that in mind. Always, always, always remember that. PCAs are great to remember that because they deal with these patients a lot. But that's kind of the gist on this and the medications. The next thing that I wanna briefly talk about is this for sure. If you've ever seen this valve, we have a great picture in our text. This is called a stopcock. This is a valve that's sometimes used on pegs, but more often on J-tubes, which is in the jejunum. We'll go over that in class, but I just want you to see this because we do have this option. But you need to make sure when you're looking at this, usually this orange port is on the patient. This would be on the patient, and this is your external valve. So if the arrow is on, then that valve is on, and this is off. So if you were going to be giving a feed, you want to make sure you got arrows going in both ways so that this opens this valve and this valve. Sometimes that can be confusing because you feel like you're constantly turning arrows, but you just want to make sure if we want to turn the feed off, then that's a good way to do that because this would be what you were connected to for your feeding. Okay, so that's called a stopcock, just for a demonstration. Okay, so real quick, I want to just give you some real life pictures of TPN. We learned last semester, I hope that you have parenteral nutrition and enteral. This is an example of enteral, into the gut, into the gut. Parenteral is into the peripheral system or the circulatory system. Do not be confused with peripheral, meaning that that's a peripheral line, because we know that TPN needs to be in what kind of line? Central line. This is an example of parenteral nutrition that can be in a parental line or a peripheral line. It does not have lipids and fats. You see the difference in the color and the concentration? This is very milky, very thick, and this is very thin. So this is just a good example of what these look like, and I just want to show you because we do have these in the lab. We'll go over and over and over again when to use these and how, but I just want to give you a good picture of that, okay? So I think I've covered everything.